Okay, good evening to everyone. So let's carry on where we left last week. Just this morning when I was still working on the talk, I just discovered that our mascot is also involved in cholesterol. I didn't even know that tomato could have an impact on the level of cholesterol, both total cholesterol, increasing HDL and decreasing LDL. So the agenda is basically following last week cardiovascular disease significance and prevention. We assess the risk. We reviewed the lab test and we discuss strategies that are available to us and that we should be able to offer to our patient to be able to reduce level of cholesterol and prevent cardiovascular disease. Today, we will start with which statins are available. We will restrict ourselves to the one that we have in public sector. What are the dosages and dosings? What is the significance of statin when it comes to primary and secondary prevention of cardiovascular disease? And we might not finish everything. The most important thing is that the little that we learn, it is something that we've added to our knowledge, and as long as we can apply it and make a difference in our patient, that is worth it. So in our setting, I hope we all know that we have access to either statin or to Simvastatin or Atorvastatin. CHCs and the clinics only have access to Simvastatin, so almost every single patient at the clinic that was prescribed statin will be on Simvastatin. And in hospital at CMH, we have access to Atorvastatin, but it is not as freely and at time as Simvastatin, and at the time it needed to be motivated for the patient to get Atorvastatin. So Simvastatin comes as a tablet of 10, 20, and 40 milligram. I think that in hospital we only have 10 and 20 milligram. Atorvastatin can be found as tablet of 10, 20, 40, and 80 milligram. Currently at the hospital, I think we only have 10 and 20. And there was a time that we only had 10 milligram available. So the first question will be, how much do you start with when you think of prescribing statin? And if we go back to most of our patients, unfortunately, we don't have audit data from audits. It's usually a standard dose. Most of our patients will be started on 10 milligram of statin, Simvastatin, and even when we put them on Atorvastatin, by default, it is always, most of the patient will be offered 10 milligram. But the data that are out there suggest that whenever you want to start your patient on statin, you must have the end in your mind. So the end meaning the target in your mind. So we should not be having a default dose, starting dose that is blanket for every single patient that we deal with. So it should be individualized, and it is determined by the baseline LDL and the target LDL based on the patient risk level. And this will be guided, basically it will be based on what is the expected reduction of LDL for that patient, and that is a window to your patient therapy intensity. So we need to have that in mind and shy away from a default 10 milligram or a default 5 milligram of statin whenever we wanna prescribe statin for our patients. So we need to remember that it should be based, it should be individualized, and the guiding principle will be what is the patient LDL, what is the target for that specific risk, and we'll calculate the expected reduction and determine which intensity of therapy that is indicated. Therefore, once we know that, they suggest that doing that exercise will help us and our patient to attain the goals sooner without fear of side effect, because data are there. We can start with higher than what we are used to without increasing the risk for side effect. And the nice part here, because we treat to target, if we can attain and sustain the goal, if we can attain the goal earlier and sustain it, that is even better for our patient. So basically, depending on the risk, you start your patient and you need to up titrate as soon as possible, because you would have known already how much your patient will need long before even the time for testing the response on the lab or on the blood. You should be planning to increase your patient treatment by 4 weeks. So determine how much your patient need so that you get there as soon as possible in one up titration that will occur 4 weeks from the time that you've initiated your patient on treatment. Doing that, you get your patient to always be offered an optimal therapy, because it's not all about starting statin, but starting the correct dose of statin for you to be able to get your patient to target. So, and once we start treatment, we need to know that every time we've increased the patient treatment, the lab test should be repeated up to 12 weeks, early as 4 weeks after changing the treatment, and on average by 2 months. Every single patient on statin should ideally get the blood test done for us to assess the response to treatment, and also indirectly assess adherence to both lifestyle and therapy. And once they are at goal, then it can only be repeated 6 monthly. There are also guidelines that allow yearly repeat of blood once the patient has reached the target. So again, it is critical that we discuss intensity of statin. And what do we mean by intensity? It is all based on which percentage of LDL reduction your patient need to achieve or to attain the target. So there will be patients based on the baseline that might need less than 30% of the baseline LDL to be reduced. There will be patients that will need more than 50% of LDL to be reduced. And there will be also patients that might need between 30 and 50%. And for each category of reduction here comes the intensity. So when you reduce your patient LDL by less than 30%, or when the need, the reduction, the required reduction is less than 30%, it means you need to prescribe low intensity therapy for your patient. While when your patient baseline is way above 50% of the target, then your patient need to be prescribed or to be offered high intensity therapy. And for simvastatin, as you can see, every time you prescribe 10 milligram of simvastatin, you only offered to your patient low intensity therapy. And between 20 and 40, that is moderate intensity. It means you can only reduce less, not more than 50% when you offer 20 to 40 milligram of simvastatin. Although 80 milligram is considered to be high intensity statin therapy, it is not advised to prescribe 80 milligram of statin. We'll discuss that again. So as you can see, with atorvastatin, there is basically no dose that is weak enough to be considered low intensity. So every time that you put your patient on atorvastatin, or all your patients that need more than low intensity should either be on 20 to 40 milligram of simvastatin or 10 to 20 milligram of atorvastatin. And when you prescribe 40 to 80 milligram of atorvastatin, that means your patient is now on high intensity statin therapy, and that is the only time that you can reduce your patient LDL by more than 50%. So again, just when we assess the risk last time, we could remind one another that all of us should have on the top of our mind which category of patients are very high risk, which category of patients are high risk. The same way, we should also remember on the top of our mind which patient, even without calculation, will warrant high intensity statin therapy. So every single patient with a non-cardiovascular disease need to be offered high intensity statin therapy. So irrespective of the level of LDL. So it's patient with myocardial infarction or post-myocardial infarction, for example, or patient with peripheral arterial disease or lower extremity arterial disease, patient post-ischemic stroke should be offered high intensity statin, meaning not simvastatin, because there is no dose of simvastatin that is safe and that will meet the requirement for high intensity therapy. So basically all those patients should be offered atorvastatin. If the hospital cannot offer and your patient is lucky enough to have a medical aid, you need absolutely to use your patient medical aid and access high intensity therapy for them. So what is the maximum dose? So as we saw there, the maximum dose is basically for simvastatin will be the safe maximum dose. provided that it is tolerated, it will be 40 milligram, and the safe maximum dose for atorvastatin, provided that it is tolerated, will be 80 milligram. And please, again, it is not recommended that a patient is offered 80 milligram of simvastatin, even if they need it, even if they fall short of achieving the target with 40 milligram of simvastatin. That means they need to be switched to atorvastatin, and in other setting, some other drugs, some other statin that will do that work. So let us not forget, please, because of the high risk for complication or adverse event, we should really avoid offering our patient 80 milligram of simvastatin. So what about renal dosing? Because again, patients with a eGFR of less than 30 are considered to be very high risk. It means they will need high intensity statin. From time to time, we have patients that are diabetic that will end up having CKD. We have a patient with hypertension that will end up having CKD. A lot of patients with cardiovascular disease end up having CKD. What do you do when you have a patient with CKD? Do you need to worry? Do you need to adjust your patient dose or not? So there is no adjustment that is needed, being it with simvastatin or atorvastatin. Not even when you start exactly the same way. The maximum for simvastatin is 40. That is the same maximum that we've reminded ourselves to also apply to any single person that is on simvastatin, because we don't want to expose them to risk of myopathy. So we've seen a lot of patients that got the statin drop because the eGFR was dropping, or because the chronic kidney disease did progress. So the recommendations are clear. There is no dosage adjustment that is needed at any degree of kidney dysfunction, being it for simvastatin or atorvastatin. So what about hepatic impairment? Do we even worry about it whenever we prescribe simvastatin? Because we've seen in practice people being worried about kidney function, but what do we do when we deal with a patient with hepatic impairment? So again, statin will be contraindicated in every single patient with active liver disease, or in any patient with unexplained persistent elevation of serum transaminase. And we have quite a number of patients, especially in the HIV population, but fortunately, in the HIV population, transaminitis is explained. We know that it is explained, but whenever you find a patient that has a transaminitis that you cannot explain, even if they need a statin, you should, the recommendation are that you should avoid putting them on statin. So now there is another issue as we prescribe. So we know which drug to prescribe. We know which dose to start with. There is no blanket 10 or 5. Every single initial dose is based on the baseline and the target me implying getting to assess which dose will get us to the target based on the expected reduction. And we divide basically that dose by 2, and we start our patient with half of what they need, because 4 weeks later, we will increase to the maximum that will fit that particular intensity. And we reminded one another again, what is all about intensity. It is based on how much LDL will be reduced. Baseline LDL will be reduced between less than 30 and more than 50, more than 50 for high intensity, less than 30 for low intensity, and in between moderate intensity. So now that we prescribe, we know so which maximum not to go beyond. When do we tell our patient to take the treatment? And why should we be telling them that? What are the determinants for us choosing the timing for that particular dose of statin? So the determinants are the fact that cholesterol peaks at night. We need to remember that. And what we need also to remember is that all statins don't share the same half-life. There are statins that have long half-lives, and there are statins that have short half-lives. So that those two elements that will help you decide what time you should advise your patient taking the treatment. So the current evidence again are that every single patient that has been offered short-acting statin should be using it at night. And patient with long-acting statin can use it any time that is convenient for them. So it makes life easier, especially in the context of polypharmacy. And if somebody doesn't want to forget to take statin because they've been forced to use it at night, when they have long-acting, they can take everything in the morning and forget about the treatment. And Simvastatin half-life is less than 5 hours. That is why Simvastatin is prescribed at night and should be used at night to take care of the time where cholesterol is at its peak, while patients on atorvastatin should not be forced. They should be allowed to choose whenever they want to use it, what the time that is convenient for them for better adherence. And the half-life of atorvastatin for the parent component is 14 hours, and for active metabolite, it can go even beyond 30 hours. That's why that is the difference between prescribing simvastatin and atorvastatin. It is based on the fact that we considered the physiology that cholesterol peaks at night, and not all statin can last longer to be able to cover the night when they're taken in the morning, because by the time, if the patient takes simvastatin in the morning, by the time cholesterol will be peaking, there won't be any drug to take care of it. So why does it matter that we will be prescribing or relying on statin for our patient? As we say again, we want to prevent cardiovascular disease, and we know that under vascular disease, one of the entity among the five listed condition, it is atherosclerotic vascular disease. And again, we know that 85 of cardiovascular deaths are related to heart attack and stroke. And we know that heart attack most of the time will be related to atherosclerosis, and the majority of stroke are ischemic. Also, atherosclerotic vascular disease is in the background. And again, as we discussed last time, 3 out of 4 of these patients that will be dying because of cardiovascular disease are our patient that we deal with every single day. So, and because of that, and because we know that the bulk of cardiovascular disease is atherosclerotic, and because we know that atherosclerosis is mainly caused by and perpetuated by LDL, decreasing LDL will definitely take care of cardiovascular disease and reduce cardiovascular disease, preventing mortality and morbidity and even disability. That's why we need to prescribe statin to our patients, and we need to reduce LDL in our patient. So, and you can read all the guidelines almost all over the world. The cornerstone of cardiovascular prevention is one of the cornerstone is statin. Yes, we need to promote lifestyle modification, but at the end, the biggest difference is made by statin. These are just data that I will be providing to you to show you how critical it is to prescribe statin to our patient. As you can see here, when compared to placebo, all cause of mortality were reduced significantly when a patient for primary prevention was offered statin. Same apply to fatal and non-fatal cardiac disease, cardiac event. So these are again data when you see, just to give you an idea of the impact of statin when it comes to primary prevention based on the number needed to treat over 5 years. There are different data, there are different trial out there for primary prevention. But again, still data out there when you read this trial. So for every single 1 millimole of LDL that you reduce in your patient, you have more than 10 fewer major vascular events in 1,000 patients over 5 years. Again, this is just data out there that prove to you and to all of us how critical it is to prescribe statin when indicated in patient. And this trial was a multi-centered trial that had also a center in that was also including patients from South Africa. So based on these data, the recommendation are that almost every single patient with a cardiovascular risk of about 7 0.5%, or if you are using the NICE guideline, 10% should be offered statin for primary prevention. So this is a reminder that not only we need to treat patient for any other cardiovascular disease or any other condition, but we need to be mindful, especially in the adult population, to get used to determine the level of cardiovascular risk in our patient. And whenever it gets to about 10%, remember that lifestyle alone might no longer be enough, and the patient will need and will benefit. Not only the patient, but the patient and the nation will benefit from us offering them statin. This is one of the grading of the cardiovascular risk that we are used to when we use the Framingham. So we know that it is all about less than 3%, between 3 and 15%. So basically, from a moderate risk, because that is where 7.5 and 10% fall, patient will need to be on statin. The only patient that might not be on statin for primary prevention would be the patient with mild cardiovascular risk. And this is just a summary. As you can see, the evidence and the class of recommendation is 1A. So there are randomized control trial to back up that recommendation. That is
this other friend of mine I met today.
Somebody must unmute. Mute.
I've sorted it.
Okay. So as we can see there, it is a class 1, class 1 and level of evidence A, whenever those patients are offered statin. And something that came up, this is just a recent review that was done. It was as if the recommendation from the American Heart Association and the NICE could be considered to be preferable whenever you wanna choose a patient that need primary prevention and be offered statin for that purpose. So, and another issue, as we spoke about intensity, yes, we will reduce, statin will reduce, but at the time, the number needed to treat depends on the intensity. So the higher the intensity, the lower the number needed to treat. It means how do we call it again? That modality is more effective in reducing the cardiovascular risk. So your patient on high intensity, as you can see there, the number to treat is lower compared to the number to treat in moderate intensities. The lesson here is that if your patient you have a population that need high intensity and you give them moderate intensity for primary prevention, for us to prevent one event, we will have to treat more patients than when they are offered high intensity statin. Again, this is just another review to back up how critical statins are when we give them to our patient for the purpose of primary prevention. Not only they are effective, but they are also cost effective. And this is just another summary to again remind us how significant statin are, and not only starting them on statin works, but when you keep them on statin longer, the benefit is even higher. So as you can see here, when they are offered and they're only reduced by 1 millimole, you cut by a quarter, but patients that will have been on low statin lowering agent for a long time can get their cardiovascular mortality reduced by half. So it is important that not only they are offered, they start the statin, but they are kept on statin, and we need to explain this to our patients so that they keep the treatment. Again, as we spoke about intensity, because intensity is based on the risk, the greater the risk, the greater the benefit, or the greater the reward. So the higher the risk, the largest absolute, the larger will be the absolute benefit of statin therapy. And this apply also, this is a segue to secondary prophylaxis. That this explain the reason why the number to treat in secondary prophylaxis is even lower compared to the number to treat in primary prevention. It means the patients that are already having atherosclerotic cardiovascular disease benefit even more when we give them a statin. Hence, we should not be missing them. Dealing with diabetic patients, then we get to appreciate we should not be waiting for them to develop angina for us to know or to remember that they might have atherosclerotic disease. But whenever we monitor them, how many times did we take time to check the pulse? Because every time there will be decreased pulse, that person should get high intensity, and that patient should be on statin and be kept on statin for them to reap the benefit of it. So every single patient, we spoke about this, with established arteriosclerotic disease should, almost all of them should be on statin for secondary prevention. And not only they should be on statin, but most of them will be on, might need more than 50% reduction of LDL, meaning they will need atorvastatin in our setting. And again, the recommendation, as you can see, the class of recommendation and the level of evidence are quite the top, except for when you only want to give them lifestyle first and add the drug when they fail to be controlled, then the recommendation is strong, but the evidence is not as strong as when they need to get both lifestyle intervention and concomitant drug therapy. So as we spoke again, you can see there, when you compare the numbers in primary prevention with the numbers in secondary prevention, the number to treat becomes lower. It means the modality is more effective and should not be denied to our patient. And this, again, it's just across the risk, across the level of LDL, whenever arteriosclerotic vascular disease is there, and you offer statin for secondary prevention, that leads to a clinically important reduction in the risk of both MI and ischemic stroke. This again is just data to back up the recommendation. Again, it's not about I've started somebody on simvastatin, I've started somebody on 10 milligram of atorvastatin, now the patient is at moderate. The higher the intensity of your statin therapy, the higher the benefit and the lower the mortality or the complication. So let us move from just giving statin, but trying to give the intensity that is required, because the benefit depends on how much LDL we've managed to decrease from the baseline for the patient to be safe and for us to see less mortality. This again are data still to back up the recommendation. This is again the data. Remember, we spoke about the new criteria. We say one of the risks in isolation, if it was excessive, it made your patient to become a high risk. And one of the new risk that is considered to be excessive now is your patient LDL alone. So the higher your patient LDL, the higher the risk. And every single patient with a higher LDL, when you offer them secondary prevention statin base, they reap more benefit, and death or mortality is reduced significantly. So we spoke about intensity. Intensity is not about drug. So you can move from simvastatin to atorvastatin, but if you only gave 10 milligram while your patient need 40 milligram because they need high intensity, you would have missed the point. So effectiveness is not based on the drug, it is based on the intensity. So 10 milligram of atorvastatin will do the same job that 20 to 40 milligram of simvastatin. So we should not be moving every single patient that need moderate intensity to atorvastatin, because it is not based on atorvastatin per se, it is just based on which intensity we've been offering to our patients. So unless there are contraindication or there are drug-drug interaction, or unless the patient doesn't tolerate simvastatin, then you can move the patient to atorvastatin, because what matters here is that did you give the correct intensity or not. So to close the talk, we can appreciate that not only the risk is important, but prescribing the correct intensity is equally important. Just a reminder again, it is all about how much we should be reducing from the baseline and which modality can get us achieve that reduction. Never prescribe 80 milligram of simvastatin and 10 milligram to 20 milligram of atorvastatin. That is more expensive than 20 to 40 milligram of simvastatin does the same job. So if your patient doesn't need high intensity and your patient is tolerating simvastatin because it's cheaper, then just prescribe the correct dose. And that is just another summary. As you can see, the numbers in the rows under secondary prevention, when you compare them to numbers in primary prevention, they are smaller. It means statin works in both primary prevention and secondary prevention, but statin works better and are more effective for patients in secondary prevention compared to primary prevention. Thank you very much.
Thank you very much, Dr. Kay. You certainly made the case there in terms of us, and we're getting much better now in managing dyslipidemia. There's been a couple of questions, not all of them was on the public chat. And it's just to clarify what Dr. Kay has been emphasizing, that when we're managing dyslipidemia, it's a little bit different than when you're managing diabetes, where you start off with a certain dose and then you adjust your dose according to what your morning sugars are doing. In this case, you're already deciding at the beginning how much simvastatin or how much atorvastatin you're going to need to give, depending on that intensity treatment. So to make it simple, step one, you figure out your risk. Is my patient low, intermediate, high risk, or very high risk? All of that stuff that was in that first lecture. Step two, you look at what the LDL cholesterol goal is, depending on their level of risk, and you look at what the LDL is at the moment. So that's where you figure out what percentage reduction of LDL you're going to need. Then you look at your different drugs to see if you're going to need low intensity, medium intensity, or high intensity to get down that depending on that percentage, and you pick your dose. So you might look at your patient and go, my patient is going to need simvastatin 40 milligrams to get this down. But because of the side effect profile, we're going to start low, 10 or 20 milligrams, and we're going to build that dosage up over a 4 to 8 week period, at which point we'll repeat our lipogram, and then you're going to repeat that exercise again. Dr. Kay, you can just correct that very brief summary. So you already have your goal in mind when you start your treatment. And then of course your lipogram is going to guide you along the way as well.
Yes, but we need to remember that one of the reality on the ground is that whenever we start very low, first, we should not be worrying about side effect, because you can start even with the maximum that is needed. It has been proven that the likelihood of side effect is comparable. The patient that started with lower dose, but because they were prone to reacting to the drug, they got side effects. So the easiest way is just you get your needed dose, just divide it by 2, so that it is also easier for your patient. They know that they will get there in 2 steps, and you might not forget to up titrate, because what happens usually is that we start, but we forget to up titrate. And for example, if your patient needs moderate intensity, you know that it is 10 to 20 milligrams of atorvastatin or 20 to 40 milligrams of simvastatin. So you just go half of that, you give to your patient. You might not even need, in 4 weeks' time, you might not yet need even the LDL, especially if you start, your half was less than what is needed for that particular intensity. You should just escalate long before you get to time to test the lab. Yes, in private, you might do your LDL as earlier as by 4 weeks, because it does start working by 2 to 4 weeks already. So, but in government will struggle. If you order your patient lipogram after 4 weeks, they will reject it.
And you might have, if you're in a clinic, you'll really struggle because of the access to atorvastatin. If you're in a larger hospital where you do have access to atorvastatin, you might have to show your pharmacist these presentations, because sometimes pharmacists might not be happy to start on atorvastatin. They might be saying, no, you should start on simvastatin and then slowly build up. So that could be a challenge in starting with atorvastatin at the beginning. But if you talk to your pharmacists, everything is possible. We've been doing that at CMH.
So what the take-home message here will be, so every single patient post-stroke, ischemic stroke, that is on simvastatin, have been robbed, basically, because there is no simvastatin dose that will work for that patient to get to target. The only time that we shy away from the target is when they couldn't tolerate. But let us keep in mind that a patient with stroke, a patient with angina, a patient with those are the most common conditions that we deal with, a patient with lower extremity arterial disease, which is called peripheral arterial disease. That best medical therapy that we talk about is not best until your patient is having high intensity. So you give 10 milligrams of simvastatin, don't call it best therapy for your patient.
Thank you very much. That's very clear, very helpful. I just want to see if there's anybody that has any questions. You can either put them in the chat or you're just welcome to unmute yourself if you have any last questions about dyslipidemia before we let Dr. Kay go on holiday. I do see there's a question here about, yes, so about if you're say you've decided that your patient's going to need 20 milligrams or 40 milligrams simvastatin and your LDL is not getting to target, then yes, you need to upscale and you would need to use atorvastatin in those circumstances. So that's just the one question there on the chat. There was a question as well, Dr. Kay, from earlier on about what do we do with patients who do have liver disease? Do we have any options for them in terms of primary or secondary prevention?
Oh, there are the new agents that are available now, but they will be only available in private. So we will struggle for patients in public sector, unfortunately.
Thank you very much. Any last questions? I think we've.
Dr. Magwenju wanted to
ask something, Doc?
Hello, Doc. Do we have access to bezafibrates in CMH? And what is the standard recommendation as in when we should start a patient on bezafibrates instead of statins? Thank you.
So first, the primary treatment for, because fibrates have been prescribed mostly for triglyceride. But whenever you have a patient with high triglyceride, the primary treatment is statin. Because most of the statin, when you read about them, they will reduce by 30% at least the level of triglyceride. So, and if you go through the guideline also, even in South Africa, they will tell, except for patients with very high risk, you need first to get the LDL to target. Only when the LDL is on target, but the triglyceride is still off target, there you might need to add fibrate. And whenever you, fortunately, bezafibrate is safer compared to the first generation of fibrate. There were drug-drug interaction whenever you choose a fibrate. So people should be mindful of that. There are fibrates that are discouraged to be combined with statin. But don't go for fibrate unless your patient is at risk of pancreatitis because of the level of triglyceride. But usually you need first to control LDL, then add fibrate when triglyceride remains above 1.7 or 2.3, somewhere there.
Okay, Dr. K. There was a patient we saw 2 weeks ago with acute pancreatitis. So when the patient has acute pancreatitis, do we have to combine the two, statin and bezafibrate, or do we start only on one? Thank you.
Was it alcohol related or
yes,
not alcohol related?
Alcohol related.
No, the alcohol related, the mechanism is different from triglyceride related. So we don't prescribe fibrate for alcohol related pancreatitis.
Oh, okay. No, thank you.
And then Dr. K, there's a question here. If there's ever a scenario which you would consider down titrating the dose of the statin, and what do you do if a patient does develop the myopathic side effects, but is at a high risk of cardiovascular events?
Okay, first, there are no recommendations. Remember that the motto now in statin is the earlier, the longer, the stronger, the better for your patient. So because the target today is if we can get to a LDL of even less than 1, that will be the ideal. So if you stop treatment, it will go up. And remember that there are patients that need, in secondary prophylaxis, for example, but secondary prevention, they need a high intensity regardless of LDL level. So the drug must just be there at that intensity, even if the LDL is below the target that it might not even be elevated, but you need to keep your patient on that statin. So the other issue was if they develop side effect, the recommendation are that you need to stop, get the side effect reverse, then switch to another drug, start with a low dose and monitor your patient again. So basically, if they react to simvastatin, you need to stop simvastatin, wait until the CK goes down, or wait until the pain is totally gone. Then ideally those patients should be moved to atorvastatin that has less likelihood of myopathy, for example, than simvastatin, and you watch out your patient.
Excellent. Thank you very much. I think that's all the questions that's come up. Thank you very much, Doc. We're looking forward to continuing in May, and I think we're thinking about asthma as the next series, asthma and COPD possibly, and we have found this very, very valuable, and I will again make the recordings available, and feel free to distribute this to other doctors that you think might find this useful. All the best, everybody. Have a lovely evening, and Dr. Kayembe, have a lovely holiday.
Thank you very much. See you in May.
See you in May. Okay. Bye-bye, everybody.